Today we're going to be discussing different medical, psychosocial, and psychological aspects of disability. First, social aspects. And we've kind of covered some of this before. Perceived causes, societal attitudes are often determined less by the actual cause of the disability and more by what society perceives the cause. Supernatural causes. Earliest record of explanation for disability includes demonic possession, punishment for doing some wrong, medical causes, humoral pathology, something in the body just does this. Natural causes led to humane sanatoriums in the 2nd century and the development of asylums in the 18th century. And society as a cause, meaning that mental illness caused by social institutions, for example, capitalism, victimization, interactions within the family, and of course later on in the 20th century, with the advent of medications that helped people, and as well as with assistive technology. This led to the movement for deinstitutionalization, for moving people back into the community, led to group homes, led to the concept of normalization and independent living. In terms of responsibility, sometimes there is a sense that society assumes that the person, quote, deserves to have the disability and they deserve to be blamed. This relates to the sense of personal responsibility, meaning that the person with a disability is seen as culpable and can expect less compassionate concern than the individual whose disability is perceived to be due to circumstances beyond his or her control. So there are, for example, you could say that certain risk-taking behaviors might have led to the disability and the person is responsible for those. However, there's different perspectives on that. How do we view people who develop different forms of cancer because of lifestyle choices that people make? Or if someone develops paraplegia because of an accident and they were drinking, who was responsible? Societal responsibility, blame for disabilities on the attitudes and inaccessibility of society. So what does that mean? Well, it means that that society always is a social environments and social conventions and institutions aren't always accepting and welcoming of people with disability. So I want you to just think about the perception of disability and perception of responsibility and who is responsible. And does the person hold the responsibility? Is the person perceived as being responsible for the disability? Or is it somehow behaviors of the person related to that? Or is it just something that just happened to the person and they had nothing to do with it? So, for example, if someone is at work and the machinery breaks down, causes an injury, then the person may view him or herself as a victim and not be responsible. So there are different ways in which we perceive a disability. Perceived threat. This is an interesting concept. Often society fears personal safety and economic well-being because of people with disabilities. Threats to personal safety include fear of physical violence, an illness that may be contagious, such as leprosy or AIDS. Of course, the level of being contagious depends upon sometimes the behavior of the person. Fear of behavior towards people with disabilities. Sometimes people feel that people with mental illness may be prone to being violent. Homeless people may be prone to outbursts of violence. Another threat can come from the threat of economic well-being. Employers sometimes assume that individuals with disabilities are going to cost more, that benefits are going to be more costly, which is not always the case. Then we have reactions to disability. We have denial, we have overdependence, we have passivity, withdrawal, aggression, we have enabling behaviors, codependency behaviors. We have self-esteem, where the individual may feel inadequate as a reaction to the disability, especially where physical appearance and body wholeness is viewed very favorably. That's not the case in every culture, but it certainly appears to be in ours, where youth and health and good body image is stressed. You see that in magazines, you see that on television, you see that in the internet, and so forth. Emotional stress can be brought on by feeling a loss or suddenly not in control. Denial someone who goes into denial this can be a defense mechanism to lessen emotional stress. And sometimes frustration that people have leads to being aggressive, refusing rehabilitation, refusing medicine, medications, refusing treatment, therapies, and so forth. And that can be a function of denial, or it can be a function of the person saying, I'm going to get better, so I don't really need any rehabilitation type of program. Adjustment now this is an interesting concept in terms of adjustment, because what we have would be a developmental sequence, particularly a developmental sequence in terms of reaction to a disability. And I think I want you to contrast this, or at least think about it in terms of the difference between developmental disabilities, which are obviously disabilities that individuals have had at or near birth, and the way the person is the way the person always has known him or herself, versus traumatic or gradual onset types of disabilities. And in traumatic or sudden or even gradual onset disabilities, people often go through a sequence, and this sequence can include, you see two of them on this PowerPoint, shock, denial, depression, depressive reaction against independence, and then adaptation. Another model related to this would be first shock, expectancy of recovery, mourning, defense, and then finally adjustment. Another model would be uncertainty, shock, denial, depression, grief, mourning, and then acceptance. So these will all be different concepts or stages that people go through in the adjustment process. And obviously not all individuals go through these stages or experience all of these stages in the same way. Each person's reaction will be different. And this can relate to differences between individuals in terms of the age of the person, the prior experiences of the person, the gender of the person, the ethnic background of the person, employment of the person, and it can also be a function of expectations of secondary gain. Sometimes people are, believe it or not, when they have an injury, feel some degree of relief in the sense of being excused from the normal societal responsibilities. So if you couple that, if someone has an accident in which they're going to be compensated for it through some monetary payment, then that would cover the cost of their maintenance. And they are now excused from, let's say, working. And that can also be a function of the person's support network and the expectations of others, and enabling behavior on the part of others, and also codependence, where people kind of function together, a non-disabled person being dependent on the person with the disability. And There's a lot of interactions that come about here. One of the things, though, that typically what we see, especially with traumatic accidents, is that they often happen to younger individuals. Now, obviously not all the time, but many times they happen to younger individuals who are the ones who tend to be in a higher risk-taking group and tend to have thought the least about having an accident or an injury. So this could be something related to an automobile accident and the person becomes paralyzed, or a motorcycle accident, or diving into a shallow pool, or things like that, where the person now becomes paralyzed. And these stages of first being in shock or being uncertain, and of course during the early phases of these adjustment stages, the person has a lot of attention. You know, there might be family members, there might be significant others, there might be, there'll be treatment, there'll be services. So there's a lot going on in the person's life. So in the first few stages of shock and then denial, a lot is going on. Sometimes people's denial can lead to or be part of expectancy of recovery, where the person thinks, well, I'll get better. This can't be something that's going to be long term. Let's say a person has a spinal cord injury, and then as the treatment kind of ends, or the person achieves as much as they're going to achieve, then and they haven't gotten better, then the person may go into a sense of being depressed, and this can lead to grief, and it can lead to mourning. And then finally, the person would come into some degree of adaptation or adjustment. And that adaptation or adjustment may be a negative one, or a positive one, or a combination of negative or positive. It may be positive in the sense that the person is willing to learn new job skills, but negative in the sense that the person becomes dependent to an extent that's greater than necessary for independent living areas. There can be negative in the sense of unrealistic expectations of recovery. It can be positive in the sense that the person has an understanding of the disability, and now the person is ready to move forward. So there can be an awful lot of different reactions here. And there can be a lot of different ways that people go about approaching the disability and the impact of the disability on the individual. Then we have coping. I think that one of the things that I've always seen is that coping is a lifelong, I wouldn't say attempt, but a lifelong movement towards self-fulfillment, self-actualization, as Maslow might say, and all of us go through that. And disability, to me, it's not a question of looking at people as being disabled and not disabled. And I think that sometimes we misconstrue things, where we look at people and saying, you have a disability and you don't. And maybe that's in part a function of of eligibility and entitlement characteristics. In other words, you have to have certain characteristics, then you are found eligible. You don't have those characteristics or factors, then you're not eligible. And I think that doesn't mean you don't have a disability. I think that if instead of looking at disabled and non-disabled as being discrete, I would look at it more as being a continuum. A continuum in terms of all of us are on this continuum. And as we move through the lifespan, all of us move in different directions, and we develop different types of impairments that may lead to being disabling. People just in the normal aging process develop visual impairments or hearing impairments. Those are very common. Orthopedic impairments. The question is, do these rise to a level, and at what point, if they do rise to a level, of being disabling, of being limiting. And I think that's one of the key questions that we should ask. Now, we're not geared, we're not programmed to look at it that way. We're programmed to look at disability with regard to you're entitled to services, or we look at disability as you're eligible for Social Security disability, or you're eligible for worker compensation, or you're eligible for voc rehab, or you're eligible for special ed programs. But we don't look at it in terms of our own unique differences. And I would look at our own unique differences, although they may not be limiting or disabling. Well, let me take that back. They may not be disabling, they can be limiting. Some of us are very good at athletic activities or certain athletic activities, and others are not as good. We don't consider that as being a disability, but it is a difference. And to me, it can relate to being disabled for, we don't call it disabled. We don't say, well, you can't play, you didn't make the baseball team at school, so you're disabled. We don't say that. We don't look at disability in that sense. But in a way, to me, that's very similar. And, coping means, to me, that there are many options for all of us in life. There are many avenues in which we can do things, and we select those things that, number one, we enjoy, and number two, that we can accomplish, or at least we move towards doing those things, and we move in those directions in terms of the work we choose to do, the job we choose to do, and the friends we have, the things that we enjoy doing socially and recreationally, and those are the things that we focus on, and those are the things that we move towards. And we can't do everything, whether we have a disability or not. And I think it's important that we not get stuck with stigmatizing people with disabilities because they can't do certain activities, either physically or mentally, and stigmatize them because there can be many other types of things that they can do. And I think that one way to look at this is through the notion, and this is not on a PowerPoint slide, but through the notion of the medical versus the social model of disability. And this is from the World Health Organization. In the medical model, disability is seen as a personal, biological, or physical problem directly caused by trauma or other health conditions. In the disability model, in the social model, disability is a socially created problem. It's a collection of interactive conditions, many of which are created by the environment. Okay, so that's a very different approach. It's saying that disability is in part a function of the environments in which we live in. So if everybody was such that they required the use of a wheelchair, our environments would be adapted for people in wheelchairs, and the person who didn't need a wheelchair would be the one considered to be disabled. So that's the social model. And it's to me that way of looking at it says there's no such thing in a sense as being disabled. It's really a function of, and I know this is naive, but I'm trying to make a point. It's more a function of the way that society and our environments in society, our buildings and our cars and our transportation and our jobs, everything else is structured for people who have a certain way of physically and mentally functioning. In the medical model, disease, impairment, disabilities limit or prevents the individual from the fulfillment of work and independent living. However, in the social model, disability is not an attribute of an individual, rather it is a function of the person's external surroundings, which is, again, what I was just trying to say. In the medical model, disability requires medical care provided in the form of individual treatment by professionals. Therefore, the person and the sum of his or her body parts is an object of intervention. And the goal of the medical care is to make the person as close to being functional the way the majority of people are functional. In the social model, the hindrances imposed by disability can be addressed by promoting full integration, equality, universal design, wellness, and health. In the medical model, management of disability is aimed at cure or elimination of the disability or disease. It advocates for the individual's adjustment and behavior change. Again, making the person more towards the way the majority of people are. In the social model, management of disability requires consumer-driven social actions. In the medical model is very concerned with healthcare policy. However, in the social model, it is a collective responsibility of society to make the environmental modifications necessary to promote full participation in all areas of social and economic life. Therefore, attitudinal or ideological issues require social change. At the political level, in the social model, it is a human rights issue. Again, the medical model promotes the elimination and prevention of disease and disability. The social model, on the other hand, challenges the concept of a natural linear progression from normality through disease to disability and social exclusion. Now, obviously we have to make a distinction here that, in talking about the medical model and in talking about the social model, the medical model doesn't say that you don't have medical interventions. Of course you have medical interventions. You want to make sure that the person is stabilized as much medically as possible. But it's also a recognition, at least at the micro level, that at certain times if someone has a certain level of injury, at the present time the reality is this is how they're going to be functioning. And so we would want to make sure that the person achieves as much as they can from the medical model, but at some point we have to say, oh, all right, you've achieved as much as you can through your therapies, through your medications, through your conditioning, your strengthening, and so forth. But now we function at the social model level. So we take you as you physically and mentally are, and we look and see how you can adapt and how you can adjust into the world, how you can function in the world, and how we can adapt that world so that you are able to function. So one example of that would be under the ADA, where we look at essential job functions. It's obviously it's very possible that any of us or any job can be written to exclude anybody. You could say, well, here's the description for an assembly line worker. But if you throw into that description something to the effect of also have to be able to solve algebraic equations on an occasional basis, whether that's needed or not, that's going to eliminate a lot of people. So essential job functions is a way to adapt the social model to people who can't do everything or a broader range of things than other people can. Another example, obviously, would be universal design, where people who use wheelchairs and have to access steps can't access steps, so they need a universal design to enter buildings, or they need an elevator to get up to the first floor, where otherwise there would have been steps. So that would, to me, would be another example of the interface between the person and the environment in the social model. And I think that this is all part of this broad sense of coping. And we look at not functional, even though we might say this, we look at functional abilities, not limitations. We look at what the person can do. It's like looking at the glass and describing it as half full or half empty. To me, we in the social model look at the glass as half full. What can this person do? And we match what this person can do with factors in the environment. And I understand the medical model. The medical model is not going to be asking so much what can the person do, but it's going to be asking what can't the person do, what's empty, what's missing. And the medical model is designed to help to the extent possible to fill up the glass even more so that there's more abilities. It's like any time you go to your physician, your internist, or other physician, typically you don't go in there and say, well, these are all the things that are right with me, and then leave. But that's what we do in the social model. You say, this is the problem that I'm having now. I get headaches or I get dizzy, and so the medical model is designed to look to see how can we remediate that dizziness, how can we eliminate those headaches, and so it's not, to me, a question of do we go with the medical model or do we go with the social model? It's a question of these exist independently, and we certainly need the medical model, but we also function not so much in the medical model, but we function in the social model. We need to be aware of what the medical model can do to help improve the functioning of a consumer, but beyond that, we accept the person, we take the person where he or she is at, and then we move the person forward from that point. And it's important also to keep in mind that disability cuts across ethnic, gender, social, and economic lines, and it differs depending upon the person, the nature of the disability, whether the person has a physical or mental impairment, and how the person's culture, which we've talked about, and how the person's background interfaces with the individual. To what extent does the family feel responsible for caring for the person versus what extent there's an expectation that society is going to care for the person. And these at a more macro level, not micro level, micro being the individual level, but a macro level, we have people with disabilities, if they're eligible for Social Security disability, are saying that society needs to take care of the individual. And another approach would be to say, well, society really, another philosophy is society doesn't have that responsibility. Why should we pay, why should someone who's disabled, can't work, why should they be eligible to receive disability benefits? Why are we as a society paying those benefits? Maybe we could use that money for something else. And why doesn't the family take care of the individual? And these are questions, of course, they're resolved questions, at least that question is resolved. People are eligible for Social Security disability if they meet certain criteria, and the family may take care of the person to a certain extent. But it's important also to think about these things when people come to us, because what we're looking at here is a sense of whether someone has an internal or an external locus of control. In other words, someone with an internal locus of control tends to feel that they have some control over the outcomes in their lives. Someone with an internal locus of control says, I can act on the environment, and I can have some positive outcomes from my action on the environment. Someone with an external locus of control says, things just happen to me, I can't control things, whatever happens is just it just happens. I have no say over that. I lose my job, I'm out of luck. Things like that. I think we also need to be concerned with stereotyping and terminology, where we say people with disabilities are afflicted, where we say you have to accept the disability, and I think it's accept in a negative sense, that accept that you're missing something, rather than just, well, I accept the fact that I can't do this. That's a different level, a different type of acceptance. We don't use handicap anymore. We do use other terms. You hear sometimes people succumb to the disability, or the disability, the spread effect, where there's a sense that the condition spreads to all aspects of life. So a person can't hear or needs a hearing aid, and there are assumptions that they can't see either, or there are assumptions that they're unable to function on a job even with a hearing aid. So I think we have to be careful about terminology that we use, because that can affect the sense of coping. It's also important to look at disability in terms of body whole, with regard to a person's self-esteem, person's self-concept, and self-esteem, especially if there's a traumatic accident, can be based on the person's prior level of functioning. If the person can't do the prior work, that may have a lowered self-esteem, and that may impact not just the individual, but the individual's family and social network. So someone now uses the wheelchair, that may impact the person's circle of friends, because they can't get into other people's houses, and other people may feel uncomfortable being around them. So disability can have multiple facets to it. Often, as I said, family and social supports are very important, and it's important to look at those social supports and how they impact the person, and because they can have a major impact on the adjustment, especially adjustment to traumatic disability. And we, as professionals, as I always advocate, need to work very closely with support systems and with other family members, so we can enhance rehabilitation. And again, if there are secondary gains to be made, a person may lose time waiting for those secondary gains to come about. I may lose time in terms of rehabilitation participation, thinking, if I can show I'm disabled, the more I can show I'm disabled, the more money I'm going to collect from my disability policy or from the insurance company. That may waste a lot of time for the person in terms of going through and being successful in a physical or medical rehabilitation type of program. So coping is a very complex issue. It's a holistic issue, I believe. My sense is that we have to help people become goal-directed, and we have to help people move forward and be future-oriented. And certainly we build on the past, we build on a strong foundation for the person, but we also have to keep building. We can't be cellar dwellers and have people just ruminate and rummage around their old life, their old being. We have to help people say, yes, you can have good memories of the past, but now this is the current, and let's look at the future. Let's move forward so that people don't get stuck in ruts. And so that, to me, is a major part of the sense of coping and helping people to cope. Now, before I move on a little bit, let me just summarize some of these things a little differently, because what I've been talking about to a great extent is adaptation. And I've been talking about psychosocial adaptation. which means adaptation, means the degree to which the person adjusts medically, psychologically, and socially to the way he or she is with a disability or without a disability, and the acceptance or adjustment, the degree to which the person is able to understand his or her abilities. And again, I always think of these things as not you have a disability, you don't have a disability, but just we're all in a continuum. And these are things that apply to people with and without disabilities. And adaptation means that we adapt and we adjust to the way we are, and we move forward that way. And we do this all the time. You know, if someone applies to get into engineering school, they don't get in, they look at something else. The same thing with a person with a disability. They can't do a certain job, so they look at other jobs to do, and hopefully can move on and don't lose any sleep over it. And I think that to me is part of adaptation, and that to me is part of adjustment, and it's also part of helping people lead healthy medical, mental, and physical lives, there certainly are adaptations for people with disabilities. Wheelchair basketball programs come to mind. There are Special Olympics. So people with disabilities can participate in society in many different ways. And of course, as you might be able to tell, I don't like the term special to describe somebody. To me, everybody is special. We're all different, and we all should be given equal opportunities to achieve in ways that we can achieve, and to help society be open and accepting and welcoming to people of all kinds. And it's basically what I'm saying is it's just a matter of broadening the playing field, making it bigger so that it encompasses a broader range of individuals, a broader range of people. And that's really what I'm saying here. That traditionally the playing field has been for people who function mentally and physically in a certain way, and what I'm saying is let's broaden that playing field so that it can encompass people who may not fit the models that we have used in the past. Now, moving on, just some things about some of the medical areas that we deal with: the nervous system, central nervous system, brain and spine, peripheral nervous system, brain impairment, stroke, cerebral palsy, seizure disorders, epilepsy, spinal cord injury, spina bifida, Parkinson's, Huntington's disease, ALS, MS, multiple muscular dystrophy are examples of conditions relating to the nervous system, conditions of visual impairments, and of course, as we know, there are in many states agencies that work specifically for people with visual impairments, and to a great extent, these have been developed because of advocates advocating for individuals with this impairment, with visual impairments. And we see separate agencies. We see vending stand programs. We see Library of Congress with talking books. There are numerous examples of the effects of advocacy for people with visual impairments and who are blind, legally blind. And of course, you can say, well, that's all well and good. On the other hand, you might say, well, but is that taken away from other disabilities or areas, or has that come at a price, and should we play one disability group off against another? Now, I'm not saying one way or the other. I just want you to think about that, and I think advocacy is good as long as it doesn't distract from others who might be, for different reasons, equally deserving of services and of benefits. Why not a separate agency for people with hearing impairments or spinal cord injuries or mental impairments. And, I'm sure that people with visual impairments say there are very good reasons why they should have separate agencies, and I certainly wouldn't argue with that. I do think, that sometimes we need to step back and say, let's make sure that this, because we have one agency for blindness, that it doesn't take away from other people with other disabilities. There's blindness, cataracts, glaucoma, retinopathy, macular degeneration. These are all different visual impairments, which for many individuals occur later in life. Not all the time, obviously, but in many times they occur later in life. Sometimes it occurs because of an accident, an injury. Someone has a work injury, loses an eye. Other times it's just part of a natural aging process. Hearing loss, different types of hearing loss, and again, this is a very interesting area, and just as with visual impairments, the technology for people with hearing impairments has greatly expanded during the past several years, and there's no reason to think that it's not going to continue to expand, and that people with hearing impairments can be provided hearing aids or amplification devices which enable them to continue functioning and continue working, whereas previously they would have been unable to continue to work or to continue to function at the same level socially. So technology certainly has had a major impact on visual impairments and hearing impairments. Intellectual and impairments and developmental disabilities can include learning disabilities, speech and language, attention, cognitive, behavior, mobility, self-care, can include degrees of mental impairments, mental retardation, and can include now autism, Asperger's syndrome, dyslexia, dyslexia being more of a learning disability, but autism and Asperger's having certainly very strong social components to them, and in social and involvement, societal involvement components to them. Psychiatric disabilities, mood disorders are very prevalent. Depression, anxiety, panic disorders. Sometimes we'll see people with schizophrenia. We may not see people with dementia. We may see people with cognitive impairments as a result of an accident or an injury, but very frequently we'll see people with mood disorders who have what's known as bipolar. Where they have where they become very depressed or they become very agitated, and overlaying all of this is often will be substance abuse, and as we've heard or will hear, substance abuse and people with criminal records have become much more common in terms of people being provided services, and it might be that the substance abuse is the primary disability because of its impact on the person, or it might be that the psychiatric or mental or physical disability is the primary disability. But frequently you'll see physical and or mental problems coupled with substance abuse impairments. Immune system, anemia, sickle cell disease, HIV and AIDS, hemophilia. These are common types of conditions. We have a greater acceptance of HIV and AIDS. We have a better understanding of that. When that first became prevalent, there was a great sense that this was this was caused by risk-taking behaviors, and again that goes back to what I said earlier, where people are blamed for the impairment because of what they did, and they could have avoided doing what they did. Whereas other types of things, such as sickle cell disease, being genetic, the person doesn't control that. That just happens. Then there are other types of disorders, for example, diabetes, where people could say that, yes, that can be in part genetic, but it can also be in part lifestyle. And here you see that under the endocrine disorders. And I would say the endocrine disorders, diabetes probably is the most common of these disorders. Cardiovascular, we have hypertension, aneurysms, coronary artery disease, and again, with some exceptions, most of these occur in people who have not, I wouldn't say older age groups, but 40s, 50s, 60s, not a younger population. And again, from a psychosocial point of view, you're dealing with the history that the person has had, and you're also dealing with the fact that if someone has a cardiovascular impairment, if they were doing a sedentary type of job, they might be able to go back to that. If they were doing a manual labor job, they might not be able to go back to that. And you get into, again, those support system issues, societal issues, expectation issues. If someone has come from an environment in which people work for 20, 30 years, they get injured, disabled, whether it's a work injury or a cardiovascular or some other impairment that occurs, it might be that the expectation is, well, you served your time, you worked, now you collect your disability or your pension. Whereas in other support systems, other social areas, the expectation is, well, okay, you go for rehabilitation and you go back to work. And so you get different perspectives on that. And that is